Good afternoon, everyone. Hope you're having a very nice Wednesday. We are trying to get back into a little Wednesday weight loss factoids, trying to come up with a catchy name still. So apparently we're going with that for now. Last time we met and did this, we kind of talked about bariatric vitamins. So if you want to go back about 2 weeks ago, we talked about that, and it's, I think, maybe I'm a little biased, a pretty good talk about how not all vitamins are created equal. So today, I just wanted to spend a couple minutes with you over the noontime hour to have a little discussion and talk about diabetes. So many of our patients are diabetic or pre-diabetic. Maybe they take metformin, or maybe they've been on insulin for a long time. And bariatric surgery is a really incredible tool to help people with weight loss. And hi, everybody that's watching. Thank you. And so the tool of weight loss surgery changes how your body deals with sugar very rapidly. We see that especially with gastric bypass, but we can see it also with sleeve, and we certainly see it with duodenal switch as well. Long term, glucose control is pretty good with all three surgeries, but early on, the changes can be really profound. And so why does all that happen? For many of you, you might be having, hi, how are you, Ann Brown? Nice to see you. It is, for many people with weight loss surgery, they'll go home from the hospital not being on insulin anymore, or we're holding all of their diabetes medications, and you haven't lost any weight. In fact, you may go home up a couple pounds from IV fluids, and that is very new and different for a lot of people. So how does that work? Well, we can see this happen for a number of different reasons. And part of it means that weight loss is not the only driver of diabetes control. And I have somebody that's coming to join me. So let's add Dr. K. Kraja. Hey, Dr. K.
Hi.
Creating obesity app.
I know. I was still trying to change it. You got too fast for me here.
Sorry, we still care about Obesity Cares Week, even though it
We
was a
do,
month
even
ago.
though I for some reason my settings are still showing it, but I'm sure that I'll catch up here in a second. And there we go. There we go.
He's outside in the schoolyard.
Sure. Here now I'm home. I'm home. That's actually not my house. That's far too
Some
nice to
random
be my
house.
house. All right,
There's
here.
no kids' toys.
We're
Oh,
surgeons. There we are. Okay, fine.
That's our real home in the operating room.
That's right. That's
So
right.
I was just kind of tossing out the intro to, we see diabetes resolution happen really quickly. And even in some of our patients who may go home from the hospital up a few pounds after surgery.
Because we flood them with fluid.
Right. But their blood sugar is so much better. So
Yeah.
obviously there's got to be something we're doing in surgery that is affecting diabetes control that's independent of the improvements you see with weight loss alone.
Yeah. So, I mean, I think when people say like, oh, I want to treat my diabetes with weight loss, that's great.
Right.
But you don't necessarily need to lose the weight to see the diabetes improvement. And there's, as you mentioned, a dramatic diabetes improvement independent of weight loss.
Right.
In fact, in some people, we do these operations, and really we're doing it for diabetes, not for weight loss at all.
Right. And that's why we call ourselves bariatric and metabolic surgeons, because we're affecting the metabolic parameters of the body.
I called myself a neurosurgeon once because
Why?
I mean, we're changing people's cravings for food and the way their brain processes food. So neurosurgeon, endocrine surgeon. I haven't called myself an orthopedic surgeon yet, but I'll take neuro, endo, general, and bariatrics.
That's fair.
And metabolic.
I would say we help our orthopedic friends, though. We help our patients be safer for those orthopedic surgeries they might need in the
True.
future
True.
because they're more active and they're out on the ski slopes or whatever, ready to have their hip replacement more safely. So
So wait,
we
this is a myth debunking talk, right?
so no, I was really
Okay.
just gonna kind of talk about diabetes control, but we can talk about whatever you
Well,
want.
no, I thought I thought this was, as you see, I just dropped right in. No, I thought this was our myth debunking talk, but I mean, the myth could be that weight loss surgery um, helps people to improve their diabetes through weight loss, and that's not true. That's a myth.
Yeah, that helps some, but a lot of it is those all those acronyms for long named proteins and receptors and chemical
All the stuff that
signals.
you are the expert on because you are the most recently board certified obesity medicine doctor in this office.
That's right. Thank you very much. I did have to study all this for that test. I think we're learning more and more, and our colleagues who do research with little pipettes and protein molecules in labs are constantly teaching us about the different things that we are doing to affect our patients long term. So we're changing those hormonal signals like ghrelin, which is the hunger hormone. When no food gets to the stomach, when we've bypassed it into two parts, we see a lot less ghrelin. When no food gets past to set off different receptors like glucose, like peptide 1,
So can I tell
GLP-1.
you a story about
Yeah,
GLP-1? All right.
yeah. I love
So
GLP-1 stories.
so for those that are watching, there's a very interesting observation. And so GLP-1 is a hormone, and this hormone goes up after bariatric surgery, and that hormone was then implicated in the improvement in diabetes. So you have a gastric bypass. The next day, your GLP-1 goes up, and your blood sugars go down. Um, what they actually found was that people who didn't get as dramatic an increase in GLP-1 not only didn't have the same diabetes improvement, but they didn't have the same weight loss. And they were the most likely to regain the weight. So then they took it a step further and they looked at people who had versus didn't have a big rise in GLP-1. And they looked at their children or their family members who had bariatric surgery, and they were able to predict which of their family members would and wouldn't lose weight after bariatric surgery. But the funny part of this is, it's not funny like, haha, laugh funny, but the funny part of all of this is that all the drugs that we now see TV commercials for, Victoza, Saxenda, Ozempic, Rybelsus, those are all GLP-1. So
Right.
what happened is they found these hormones. They randomly found out these hormones are going up after bariatric surgery. They figured out how to make it in a lab, and now we give it as an injection and it's sold as a diabetes medication. So,
But there's still then people that aren't going to respond to that very well.
yeah. But pharma, you're welcome. Okay, pharma,
Right.
you're welcome for all the bariatric surgery that we've done to show you that these drugs are out there to help with people's diabetes.
So do we, I don't, do you check GLP-1 the day after surgery to tell
No,
people
so
how good
it's
they're
so
going to do?
hard. It's so hard to check unless you are working at the NIH or something.
Right.
From a clinical perspective, it's impossible to check, and so we
Right.
don't really know from a practical perspective. The only thing I would really take from all of that is probably two things. If you are a good responder to the medications, then you're probably going to be a good responder to surgery.
hmm
And if you had a family member who did well with surgery, you're probably going to do well with surgery. That's
Yeah, I
probably the
think I
only
think those are
conclusion.
pretty safe assumptions. And
Yeah.
at some point in the future, as medicine becomes more personalized based on people's genetics, predispositions, I do think we'll be able to offer a little bit more concierge approach based on people's underlying
Always learning.
things and always learning.
Always
Yeah,
taking more boards, Dr. Hooper.
always
More
forever
training, more boards, more CME, more CEUs.
until the wall goes all the way down with the diplomas. We'll keep
Uh,
going.
no,
They're
I
up
was
there.
actually thinking until I'm lying on a beach with a nice fruity cocktail in hand. Uh, that hopefully that comes sooner rather than later.
um, so one of the other things I wanted to talk about was sleeve versus bypass for diabetes control.
Switch. Why not switch?
Good question. Well, I think a lot of people don't ask that question because not everyone does switch like we do.
Yep.
So switch has really good over 90% diabetes resolution, meaning not on any medications,
98%
and
on some studies.
normalization of A1C. So there's no medication, there's no other intervention that can do that. And again, changing all those different chemicals and signals to our brain and to our pancreas and to our peripheral system to be more sensitive to insulin as well. Um, there was a study, and now I can't think of the name of it. I should have looked it up this morning. From the Cleveland Clinic that said
Stampede.
Stampede. Yeah,
Stampede, yeah.
yeah,
Their 1 and their 5-year data.
yeah. So looking at sleeve and bypass, and if I remember correctly, duodenal switch is not included in that.
Not included.
Yeah. Do you want to share a little bit more about that?
The Stampede study is
Yeah.
phenomenal, and
Yeah.
the real amazing part of Stampede is it was 150 patients, and what they did is they randomized people to surgery. If you think about that, that's freaking amazing. Like, can you imagine enrolling in a study? You might get enrolled like, hey, you're going to take this pill or this pill, and one's like a sugar pill. No, you're going to get cut on, or you're going to get not cut on. That's your randomization. So
Right.
I mean, I don't know that there's any other randomized control trials in surgery versus not. You might get randomized like this mesh or that mesh.
Right. Yeah.
Randomized to like surgery or not.
Right.
It's pretty mind blowing to me. But anyway, so 50 patients were randomized to sleeve, 50 to bypass, and 50 to seeing their endocrinologist every day.
And intensive weight loss and dietary
Yeah.
modifications. Yeah.
And so they match these 3 groups in terms of degree of diabetes, duration of diabetes, BMI, gender, et cetera. And so they're very well matched. And at 1 year, the surgery groups beat out the medical group in terms of diabetes resolution and weight loss. There was a decent improvement in the medical group because these are people who are not otherwise seeing their doctor for diabetes on a regular basis. And then they also showed as a secondary outcome quality of life benefit, and the surgical patients had a better quality of life. And then at 5 years, which is still freaking amazing that they randomized people for 5 years.
Right. They had
At 5 years, the surgical patients were winning, and from a diabetes perspective, the bypasses beat the sleeves. That's not surprising. We know that in general, bypasses lose more weight, get better diabetes resolution than sleeves. But switches were not part of that study. So yeah, that's the Stampede trial.
Yeah, it's really good. And I think it shows people who are working really hard to control their diabetes with weight loss and intensive control with a endocrinologist had improvements, but not anywhere near the other group.
I will say I've been doing this for 11 years, and going as far back, and we've known this for a long time, but for 11 years, going as far back as 2016, the American Diabetes Association, not like the American Bariatric Surgery pundits, but the American Diabetes Association has said since 2016, you can Google it. They put out their annual standards of care and therapy guidelines. It's like 250 pages. It's a huge PDF, but you can download it. It's free. It's open access. Since 2016, they've been saying every diabetic with a BMI of 40 should be sent for bariatric surgery. That's what they say. It doesn't matter if their diabetes is well controlled or not. If you have diabetes, E11.9, and you are BMI of 40, Z68.41.
He's yelling. He's tossing the CPT codes.
ICD codes, yeah.
Or ICD codes for office visits of those.
Yeah. Things. So if you have those two in the chart, you're supposed to be sent for bariatric surgery. I have one endocrinologist that I work with very closely, and he sends us patients. But in general, endocrinologists just don't send these patients, even though their own societies say they should be sent for bariatric surgery. So if you are one of those patients that actually cares about your own health, then and you're invested in your own care, and you carry those two diagnoses, you really should be considering bariatric surgery. There is also a misquip calculator out there. I don't know if we can.
I can probably share it.
Here I got it. I got it. Okay. Right there. I think it's coming.
Okay.
So
yeah,
the risk calculator, anybody can plug their own information in there, and you can see what your own diabetes resolution would be with the sleeve, with the bypass, or with a switch. And so that's open access based on a database of only 800,000 patients. But I think it's pretty useful.
And you and I use that every day when we're showing patients and talking about their risks and benefits with surgery. We can look at how likely is someone to have resolution of their diabetes. We can also look at high blood pressure, sleep apnea, lots of different medical conditions that go along with obesity all the time.
Yeah, absolutely.
Yeah. So to recap, bariatric surgery, best there is for treatment and resolution of diabetes. And we have multiple surgical interventions that we can offer to patients based on your health and other medical concerns that may be appropriate for that. And hopefully this was good information. Now I kind of wish you had that Obesity Action Week background again, because when you were talking about the American Diabetic Association standards, you know, even though we see lots of patients, we Dr. Kukrage is in charge of the banners, folks.
It's true.
It's totally true.
5 small incisions.
We probably only see about nationally, bariatric surgeons only see about 1% of people who meet the qualifications and recommendations for surgery. So, you know, if you're one of our post-op patients and you have family members that are diabetic and feel like you want to share your experience with them or want to encourage them to talk to us, we'd love to talk to them too, because we have all of this data that we know is so helpful for people, and that's part of our mission to help people be healthier. So have a good Wednesday.
Yeah, you too. I'll see you soon.
Okay. I'll see you. Bye, everybody.
Bye, guys.